Three main diseases are considered under the umbrella of pneumoconiosis, including coal workers pneumoconiosis, silicosis, asbestosis, and asbestos-related diseases. A wide spectrum of lung findings are seen in coal workers, ranging from asymptomatic anthracosis to simple coal workers pneumoconiosis to complicated coal worker pneumoconiosis or what's called progressive massive fibrosis. Asymptomatic anthracosis shows pigment accumulation without a cellular reaction, while simple coworker pneumoconiosis shows accumulations of dust-laden macrophages with little or no pulmonary dysfunction. At the other end of the spectrum, extensive fibrosis and compromised lung function are prominent findings in complicated coworker pneumoconiosis or progressive massive fibrosis. Progressive massive fibrosis is a generic term that applies to a confluent fibrosing reaction in the lung and can complicate any of the pneumoconioses. Although coal is mainly carbon, coal mine dust contains a variety of trace metals, inorganic minerals, and crystalline silica. Talking about the morphology, pulmonary anthracosis is the most innocuous coal-induced pulmonary lesion in coal miners and also is commonly seen in urban dwellers and tobacco smokers. Inhaled carbon pigment is engulfed by alveolar or interstitial macrophages, which then accumulate in the connective tissue along the pulmonary and the pleural lymphatics and in the draining lymph nodes. Simple coal worker pneumoconiosis is characterized by the presence of coal macules and the larger coal nodules. The coal macules consists of dust-laden macrophages and small amounts of collagen fibers arrayed in a delicate network. Those lesions are scattered throughout the lung, but centered mainly in the upper lobes and the upper zones of the lower lobes. Simple coal worker pneumoconiosis may be associated with the centrilobular emphysema. Complicated coal-worker pneumoconiosis occurs on a background of a simple coal-worker pneumoconiosis by coalescence of the coal nodules, and generally this develops over many years. It's characterized by multiple dark black scars larger than 2 centimeters and sometimes up to 10 centimeters, consisting of dense collagen and pigment. This histologic section shows progressive massive fibrosis with large amounts of black pigment and extensive fibrosis. Coal-worker pneumoconiosis usually is a benign disease that produces little effect on the lung function. When progressive massive fibrosis develops, there is an increasing risk for pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Progression from the coal worker pneumoconiosis to the progressive massive fibrosis has been linked to a variety of variables, including the higher coal dust exposure levels and the total dust burden. Unfortunately, once established, the progressive massive fibrosis, it has the tendency to progress even in the absence of further exposure. After taking smoking-related risk factors into account, there is no increasing frequency of lung cancer in the coal miners, a feature that distinguishes coal worker pneumoconiosis from both silica and asbestos exposures. Good morning, everyone. In this lecture, we will continue our discussion regarding pneumoconiosis, namely silicosis and asbestos-related lung diseases. Then we will discuss important points regarding eosinophil-related and smoking-related interstitial lung diseases. As we said in the previous lecture, the main and the most common mineral dusts include coal dust, silica, and asbestos. All of them are involved in the development of pneumoconiosis. Silicosis is currently the most prevalent chronic occupational disease in the world. It's caused by inhalation of crystalline silica, mostly in occupational settings. Silica occurs in both crystalline and amorphous forms, but the crystalline forms, including quartz, are more toxic and fibrogenic. Quartz is most commonly implicated in silicosis. Amorphous silica, on the other hand, is less pathogenic. So mostly this disease is related to the crystalline silica and mostly the quartz. And the exposure usually is related to the workplace. So workers involved in sandblasting and hard rock mining are at particular high risk. يعني الناس اللي بيشتغلوا في تعدين الصخور الصلبة أو في المحاجر هدول الناس بتعرضوا لأكثر للكريستالين سيليكا mainly the quartz وهدول الناس أكثر ريسك إنه يصير في عندهم سيليكوسيس. After inhalation, the silica particles interact with the epithelial cells and the macrophages. This results in activation of the inflammasome and the release of inflammatory mediators by the pulmonary macrophages. The inflammatory mediators released from the pulmonary macrophages include interleukin-1, tumor necrotic factor, fibronectin, lipid mediators, oxygen-derived free radicals, and fibrogenic cytokines. The characteristic inflammatory reaction mentioned in the previous slide with the fibrogenic effect and the release of the inflammatory mediator can be minimized when mixing the quartz with other minerals. So the fibrogenic effect of the quartz is reduced. And the good thing that quartz in the workplaces is rarely pure. So the common scenario to have the quartz mixed with other minerals so the fibrogenic effect is reduced. Morphologically, lung silicosis presents as silicotic nodules in the upper zones of the lung. In the early stage, silicotic nodules are tiny, barely palpable, discrete pale to black nodules, especially if the coal dust is present. This figure shows the gross appearance of the lung involved by advanced silicosis. Scarring has contracted the upper lobe into small dark mass. Please look to the yellow arrow. Note the dense pleural thickening. Please look to the blue arrow. Microscopically, the silicotic nodule demonstrates concentrically hyalinized collagen fibers surrounding an amorphous center. The whorled appearance of the collagen fibers is characteristic. Examination of the nodules by polarized microscopy reveals weakly birefringent silica particles in the center of the nodules. As the disease progresses, individual nodules may coalesce into hard collagenous scars, with eventual progression to progressive massive fibrosis. As you may remember from the previous lecture, progressive massive fibrosis is associated with extensive fibrosis and deterioration in the lung function. So it's a generic term that applies to a confluent fibrosing reaction in the lung that can be a complication of any of the pneumoconiosis. So due to the expansion of the nodules and the progression to extensive fibrosis in some cases, the intervening lung parenchyma is compressed or overexpanded. This will result in what we call honeycomb or end-stage lung. Fibrotic lesion can be also seen in the hilar lymph nodes and the pleura. This figure shows the histologic appearance of the silicotic nodule in the lung. As you can appreciate, there are concentrically arranged collagen fibers surrounding an amorphous center. At the periphery, as you can see, the alveolar spaces are still patent. This figure shows another silicotic nodules. Each is composed mainly of bundles of interlacing pale pink collagen. There is a surrounding inflammatory reaction. A greater degree of exposure to silica and increasing length of exposure determine the amount of silicotic nodule formation and the degree of the restrictive lung disease, which is progressive and irreversible. This figure shows silica crystals under the polarized light microscope. The crystals are bright white with variable sizes. Please look to the yellow arrows. So the silica crystals that are inhaled and reach the alveoli are ingested by the macrophages, which secretes cytokines to induce a predominantly fibrogenic response. And because the inorganic matrix of the crystals is never completely digested, this process continues indefinitely and is made worse by repeated exposures to the dusts that contain silica. The result is the production of many scattered nodular foci of collagen deposition in the lung, which we call the silicotic nodules, and eventually restrictive lung disease progressing into cor pulmonale. Clinically, silicosis is usually detected in asymptomatic workers on routine chest radiographs. Chest radiographs show a fine nodularity in the upper zones of the lung. Most patients do not develop shortness of breath until late in the course. After the development of a progressive massive fibrosis, the patients start to experience shortness of breath or dyspnea. Many patients with a progressive massive fibrosis develop pulmonary hypertension and cor pulmonale. The disease is described as slowly progressive, resulting in pulmonary function impairment to a degree that the physical activity is severely limited. Silicosis is associated with an increased susceptibility to tuberculosis. This happens because silicosis is associated with depressed cell mediated immunity. Furthermore, the crystalline silica inhibits the ability of the pulmonary macrophages to kill the phagocytosed mycobacteria. On the other hand, the relationship between silica and the lung cancer is still unsettled, because most studies suggest that silica exposure is associated with some increased risk. However, this topic is still controversial. Asbestos or asbestos أو الحرير الصخري is the third mineral dust associated with pneumoconiosis. Asbestos is a family of crystalline hydrated silicates with a fibrous geometry. Asbestos is one of the mineral dusts that can cause pneumoconiosis. Other common mineral dusts, as we discussed before, are the coal dust and silica. Usually, the exposure happens in workplace. This is true except for the asbestos. As with this mineral, the increased risk for cancer extends to the family members of the asbestos workers and also to the individuals exposed to the asbestos outside the workplace. So the risk of asbestos is increased in any patient who is exposed to the asbestos in workplace or outside the workplace and also to the family members of the asbestos workers. Furthermore, studies showed an increased incidence of asbestos-related cancers in family members of asbestos workers. On the basis of epidemiologic studies, occupational exposure to asbestos is linked to parenchymal interstitial fibrosis, which is called asbestosis, localized fibrous plaques or rarely diffuse fibrosis in the pleura, pleural effusions, lung carcinoma, malignant pleural and peritoneal mesothelioma, and laryngeal carcinoma. Let's talk about the pathogenesis. As with the silica crystals, the pulmonary macrophage is the key cellular element in inflammation, lung injury, and fibrosis. Following phagocytosis by macrophages, many particles activate the inflammasome. This will induce the production of pro-inflammatory cytokines such as interleukin 1 and the release of other factors. This will initiate an inflammatory response that leads to fibroblast proliferation and collagen deposition. Furthermore, the oncogenic effects of the reactive free radicals generated by the asbestos fibers on the mesothelium act as a tumor initiator and promoter. Why the mesothelium? Because asbestos fibers are usually localized in the distal lung close to the mesothelial layer. The relationship between asbestos and tobacco is interesting. In general, the absorption of potentially toxic chemicals into the asbestos fibers increases its pathogenicity. And as we all know, tobacco smoking is considered number one risk factor for the development of lung cancer on one hand, and on the other hand, and as I mentioned in the previous slides, asbestos occupational exposure is linked to the development of lung cancer too. But what will happen when the patient have both? I mean when the patient is a tobacco smoker and has an occupational exposure to asbestos. When the patient is a tobacco smoker and has an occupational exposure to asbestos, the risk exceeds the sum of each factor alone. So the absorption of carcinogens in the tobacco smoke into the asbestos fibers is the basis for the remarkable synergy between tobacco smoking and the development of lung carcinoma in asbestos workers. And in general, tobacco smoking worsens the effect of all inhaled mineral dusts and especially the asbestos. Let's start discussing the main morphologic or microscopic and macroscopic features of asbestosis. This figure shows the first characteristic feature of asbestosis. The tissue section in this figure is stained by trichrome stain. This stain highlights collagen in blue. So all the blue areas of the interstitium are expanded and distorted by fibroblastic proliferation and collagen deposition, which is called pulmonary interstitial fibrosis. The extent of fibrosis determines the severity of the disease. This is marked by progressively worsening dyspnea clinically. So the first characteristic feature is the presence of diffuse pulmonary interstitial fibrosis. Another characteristic feature is the presence of asbestos bodies, which are golden brown, fusiform or beaded rods with a translucent center. As you can appreciate at the center of this figure, there is a golden brown beaded rod with a translucent center. This is called asbestos body. The most common manifestation of asbestos exposure is the pleural plaques. The white arrows points to the tan white multiple pleural plaques on the pleural aspects of the diaphragm. These plaques develop most frequently on the anterior and posterior lateral aspects of the parietal pleura and over the dome of the diaphragm. This figure shows the histologic appearance of the pleural plaques. As you can appreciate, pleural plaques are made of dense laminated layers of collagen. This figure shows the gross appearance of two important findings. The yellow arrows point to a markedly thickened area of the visceral pleura, covering the lateral and the diaphragmatic surface of the lung. The area under the red star shows severe interstitial fibrosis affecting the lower lobe. As I said, asbestosis is characterized by diffuse pulmonary interstitial fibrosis. which is usually patchy in distribution, associated with fibroblastic foci and the formation of cystic spaces, a pattern that is known histologically as usual interstitial pneumonia. So, diffuse pulmonary interstitial fibrosis related to asbestosis is similar to the one seen in the usual interstitial pneumonia. Asbestos bodies, on the other hand, consist of asbestos fibers coated with an iron containing proteinaceous material. Asbestos bodies are formed when the macrophages try to phagocytose asbestos fibers. The iron coat or the outer crust is derived from the phagocyte ferritin. Asbestosis begins in the lower lobes and suprapleurally, spreading to the middle and the upper lobes of the lungs as the fibrosis progresses. طبعا هذا عكس اللي بيصير في السيليكوسيس and the co-worker pneumoconiosis. As we said, the pleural plaques are the most common manifestation of asbestos exposure, and they are characterized by well-circumscribed plaques of dense collagen, often containing calcium. They develop most frequently on the anterior and posterior lateral aspects of the parietal pleura and over the domes of the diaphragm. The clinical findings in asbestosis are similar to those related to other chronic interstitial lung diseases. Progressively worsening dyspnea appears 10 to 20 years after exposure. It's usually associated with cough and the production of sputum. The course of the disease is variable, so it may remain static in some patients or progress to congestive heart failure, cor pulmonale, or even death. Pleural plaques are usually asymptomatic and detected on radiographs as circumscribed densities. Regarding the outcomes, both lung carcinoma and malignant mesothelioma can develop in workers exposed to asbestos. The risk for developing lung carcinoma is increased about five-fold for asbestos workers, while the relative risk for mesothelioma, which is a very rare tumor, is more than 1,000 times greater. Furthermore, the risk for lung carcinoma is greatly increased in patients who are tobacco smokers and exposed to asbestos. But tobacco smoking does not increase the risk for mesothelioma in asbestos workers. So, although smoking increases your risk for developing asbestos-related lung carcinoma, it does not appear to increase your risk for mesothelioma, because mesothelioma development is highly related to the asbestos exposure, not to the tobacco smoking. So, tobacco smoking does not increase the risk for mesothelioma. However, as it does with all other respiratory diseases, tobacco smoking worsens the symptoms of mesothelioma and reduces the body's ability to heal. In general, lung or pleural cancer associated with asbestos exposure carries a particularly poor prognosis. Now let's highlight the main features of pneumoconiosis. Our discussion included co-worker pneumoconiosis, silicosis, and asbestos. All are occupational diseases and are related to workplace exposure. Co-worker pneumoconiosis is caused by long-term exposure to coal dust, and this may happen in coal miners, urban dwellers, and tobacco smokers. Silicosis is caused by inhalation of crystalline silica dust. Risky occupations include hard rock mining and sandblasting. Sandblasting, which is the cleaning of a surface with a jet of sand, and this is usually driven by compressed air or steam. Asbestosis-related interstitial lung disease is related to asbestos fiber inhalation. Risky occupations include construction painters, railroad workers, and miners. The reaction of the lung to mineral dust depends on the size of the particles. So particles greater than 5 to 10 micrometer are unlikely to reach the distal airways and are usually cleared out by the cilia in the large airways, whereas particles smaller than 0.5 micrometer may move into and out of the alveoli with gas exchange without causing any injury. So the most dangerous particles are the ones between 1 to 5 micrometer in diameter because these can be lodged at the bifurcation of the distal airways. And they are considered small to be detected by the cilia of the large airways and also large to be moving through the alveoli during the gas exchange. The main player in the reaction to the mineral dust exposure are the macrophages. Anthracosis develops gradually over many years of exposure and is characterized by black spotting of the lungs grossly. Histologically, the alveolar macrophages are seen engulfing the coal dust. Over many years of exposure, and with more accumulation in the macrophages, those macrophages release inflammatory mediators that results in fibrosis and may eventually result in a progressive massive fibrosis. The spectrum of change range from asymptomatic anthracosis to progressive massive fibrosis. After inhalation of silica particles, they are engulfed by the pulmonary macrophages, and this results in release of inflammatory mediators that will stimulate the cell-mediated immune reaction. However, silica particles affect the macrophages and decrease their phagolysosomal capacity with time, and that's why patients with silicosis are more prone or at higher risk of the tuberculosis infection. Microscopically, silicatic nodules show amorphous center containing silica particles and macrophages. Those are surrounded by multiple concentric layers of arranged hyalinized collagen fibers. In asbestosis, once the fibers are phagocytosed by the macrophages, they activate the inflammasomes and causing the damage for the phagolysosomal membranes, resulting in cellular and fibrotic lung reaction. And this reaction acts also as a tumor initiator and promoter. This figure shows asbestos body, which is a golden brown fusiform or beaded rod with a translucent center engulfed by a pulmonary macrophage. Asbestosis may progress to diffuse interstitial pulmonary fibrosis. The most common manifestation of asbestos exposure are pleural plaques, which are made of dense laminated layers of collagen. Tobacco smoking has a synergic effect in asbestos workers regarding the risk for the development of lung cancer. So, asbestosis is associated with parenchymal interstitial fibrosis, fibrous plaques, pleural effusions, lung carcinomas, malignant pleural and peritoneal mesotheliomas, and laryngeal carcinoma. Regarding the lung involvement, lung involvement in coal dusts and silicosis affect the upper zones in the lung, while asbestos is centered in the lower zones. The last major category of the chronic interstitial lung diseases is the smoking-related one. So in addition to the obstructive lung diseases, smoking is also associated with restrictive or interstitial lung diseases. Smoking-related interstitial diseases include desquamative interstitial pneumonia and respiratory bronchiolitis. The most striking histologic feature of desquamative interstitial pneumonia is the accumulation of large numbers of macrophages containing dusty brown pigment in the air spaces. These pigmented macrophages are called smoker's macrophages. The alveolar septa are thickened by sparse lymphocytes and sometimes fibrosis. The interstitial fibrosis related to desquamative interstitial pneumonia when present is considered mild. The gray arrows in this figure points to the collections of smokers' macrophages or pigmented macrophages within the alveolar spaces. The blue arrows points to mildly expanded alveolar septa by lymphocytes and mild fibrosis. Regarding the outcome, overall, patients with desquamative interstitial pneumonia have a good prognosis and an excellent response to steroids and smoking cessation. However, some patients progress despite therapy. Respiratory bronchiolitis is a common lesion found in smokers. It's characterized by the presence of pigmented intraluminal macrophages like those seen in desquamative interstitial pneumonia. Remember, in desquamative interstitial pneumonia, there were collections of pigmented macrophages within the alveolar spaces. So, what's the difference now? The distribution is different because here they are present in a bronchiolocentric distribution. What does that mean? This means that the pigmented macrophages are present within the lumens of first and second order respiratory bronchioles instead of being within the alveolar spaces like what we see in desquamative interstitial pneumonia. Mild peribronchiolar fibrosis can be also seen in those cases. Clinically, patients with desquamative interstitial pneumonia or respiratory bronchiolitis present with a gradual onset of dyspnea and a dry cough. The symptoms recede with smoking cessation.